Hello, and welcome to our listeners around the world. This is the JAMA Editor's Summary, and today is Friday, March 14th, 2025. I'm Dr. Kirsten Bibbins-Domingo, Editor-in-Chief of JAMA and the JAMA Network. I'm joined today by JAMA Deputy Editor, Dr. Preeti Malani. Hello, Preeti. Let's get started.
Hi, Kirsten. JAMA published a research article this week by Dr. Thovanat and colleagues. The DELAY-MS trial was a double-blind, randomized, placebo-controlled clinical trial that investigated vitamin D supplementation for patients with multiple sclerosis, or MS. The investigators enrolled over 300 patients aged 18 to 55 years in France. These patients had clinically isolated syndrome, typical for MS, with a duration of less than 90 days and were otherwise untreated. Participants also had to have a serum vitamin D concentration less than 100 nanomoles per liter and diagnostic MRI findings meeting 2010 criteria for dissemination in space or 2 or more lesions and the presence of oligoclonal bands. The participants were randomly assigned to receive either vitamin D in the form of 100,000 international units of oral cholecalciferol or placebo every 2 weeks for 24 months. The primary outcome was disease activity, defined as occurrence of a relapse and or MRI activity with new or contrast-enhancing lesions. At 24 months of follow-up, the investigators reported that a lower proportion of participants in the vitamin D group had evidence of disease activity, 60.3%, compared with 74.1% in the placebo group. In addition, all 3 MRI outcomes reported significant differences favoring the vitamin D group. The authors concluded that vitamin D supplementation significantly reduced disease activity in clinical isolated syndrome and early relapsing remitting MS, and that these results warrant further investigation, including the potential role of pulse high-dose vitamin D as add-on therapy.
JAMA featured 2 research articles this week about immunotherapy for head, neck, and nasopharyngeal cancers. Dr. Haddad and colleagues conducted a phase 3 international randomized clinical trial to investigate maintenance Atezolizumab, a checkpoint inhibitor for locally advanced squamous cell carcinoma of the head and neck. The authors enrolled over 400 patients with locally advanced squamous cell carcinoma of the head and neck. These patients did not have disease progression after multimodal definitive treatment. The participants were randomized to receive Atezolizumab or placebo every 3 weeks for 1 year. The investigators report that there was no clinical or statistical difference in overall survival between the treatment and placebo groups.
Dr. Liang and colleagues studied Adjuvant Camrelizumab, a programmed cell death 1 or PD-1 blockade for patients with local regionally advanced nasopharyngeal carcinoma. This was a randomized open-label, multi-center phase 3 clinical trial conducted in China, including more than 400 patients who were randomly assigned to receive either Adjuvant Camrelizumab once every 3 weeks for 12 cycles or standard therapy. The investigators reported that more participants in the Camrelizumab group had 3-year event-free survival, 86.9%, compared with 77.3% in the standard therapy group. Reactive capillary endothelial proliferation was the most common adverse event. The authors concluded that adjuvant Camrelizumab significantly improved event-free survival in patients with local regionally advanced nasopharyngeal carcinoma.
Dr. Posner authored the editorial that accompanied these 2 original investigations. Dr. Posner speculates why these studies have different outcomes and discusses the role of immunotherapy in head, neck, and nasopharyngeal cancers.
Dr. Loring and colleagues examined the antigenic drift of respiratory syncytial virus, or RSV, viral surface glycoprotein F, in their research letter. Antigenic drift can indicate potential need to update vaccine compositions. The researchers evaluated specimens from vaccinated and non-vaccinated individuals and found little evidence for antigenic drift in the F protein of circulating viruses in this first season after the introduction of RSV vaccines.
JAMA published a collection of content about food insecurity screening in primary care clinics. The U.S. Preventive Services Task Force issued a recommendation statement about screening for food insecurity in primary care settings. They concluded that the evidence is insufficient to make recommendations for or against routine screening for food insecurity in primary care. This recommendation was published alongside the corresponding evidence report by the U.S. Preventive Services Task Force. That report included a systematic review of 39 studies examining the impact and accuracy of screening tools that screen for food insecurity. The review found that brief screening tools likely have sufficient sensitivity to identify people with food insecurity in healthcare settings, but most studies of interventions to improve food insecurity had high risk of bias.
In light of these new findings, Dr. Garg and colleagues wrote a related editorial encouraging clinicians and policymakers to consider other effective and patient-centered approaches for addressing food insecurity. And Dr. Coker and colleagues describe the complexities of food insecurity in a JAMA viewpoint. They state, food insecurity requires direct intervention on multiple social domains that contribute to a person not having enough food for an active, healthy life and may occur in tandem with housing or transportation insecurity or childcare needs, and therefore requires resources beyond what can be provided through a clinician's office. Kirsten, you had a chance to interview Dr. Coker for the JAMA Clinical Reviews podcast. Let's listen to a bit of that interview.
I want to be really clear on this. That does not mean that clinicians should not be talking about food insecurity with their patients and their patients' families and addressing food insecurity when it comes up.
Doctors Osterer and Seligman wrote a JAMA Insights on this topic and remind readers that food insecurity is associated with poor health. Their review of federal nutrition programs is useful for both clinicians and patients. There's also a JAMA patient page that explains food insecurity and these new screening recommendations.
There are viewpoints that we published in JAMA this week. Dr. Tu and Timothy Bonis discuss a recent lawsuit against Gilead Sciences, which highlights an example of drug versioning. This means that a manufacturer delays a new version of an existing product to maximize profits from an old one, and the authors discuss this in more detail. In another viewpoint, P.J. Eric Stollard and colleagues reflected on the decline of age-specific dementia prevalence rates from 1984 to 2024.
There's JAMA Insights this week by Dr. Hess and Evie. They advocate for evidence-based guidelines and policy to help treat climate-sensitive health conditions. In another JAMA Insights article, Dr. Golakari and colleagues from the FDA discussed the recent approval of Kebilidi, a gene therapy for adults and children with aromatic L-Amino acid decarboxylase deficiency. The authors review the disease and the recent multi-center trial studying Kebilidi's effects in children.
A JAMA patient page this week focuses on dialysis, explaining potential complications and dietary considerations for patients on dialysis. The JAMA Clinical Review on Prostate Cancer by Dr. Ray Chowdhury and colleagues included a synthesis of 114 articles on this topic and summarizes the screening, diagnosis, treatment, and management of prostate cancer. The related JAMA Clinical Reviews podcast with review author Dr. Montgomery highlights key aspects of this JAMA review.
Anytime a patient gets a diagnosis of cancer, the fear is that this is something that's really going to have an impact on the quality and duration of their life. About 30% of men who have low-grade disease that isn't very large in terms of volume, they can be watched, active surveillance, and those patients have nearly 100% 5-year survival. So in that group of men, that really the vast majority of the time does not have an impact on either the quality or the quantity of life. On the other hand, when men present with metastatic prostate cancer, when we look at the whole group, at 5 years, somewhere around about 40% of them will still be alive. One of the things that I think does deserve reemphasis, however, is that we have extended median survival significantly. When I started in medical oncology, the expected survival was 2 to 2.5 years. Now it's on the order of between 5 and 7 years, and some men live significantly longer with some of the new medications that we brought to the clinic.
This week in JAMA Medical News, we have an article about using large language models to pre-screen patients for trial eligibility. This article reports on a conversation with Dr. Blood, Associate Director of the Accelerator for Clinical Transformation at Mass General Brigham. He joins JAMA Plus AI Associate Editor, Dr. Swen, to discuss his team's research in this area. Let's listen to their discussion from the related JAMA Plus AI Conversations podcast.
Can you explain for our listeners what human in the loop means?
Yeah, so human in the loop is, while the AI tool is able to perform autonomously, it has a set of tasks that it can complete with minimal human input, just really uploading the appropriate data sets to capture the inclusion and exclusion criteria and the right patients to ask those questions of. Human in the loop really ensures that, as opposed to a completely autonomous system in which an AI model or an AI agent or a computer system of any sort is able to complete processes start to finish totally on their own, human in the loop kind of puts a gatekeeper on that and allows for a human participant or a manager or really influence to step in and act as a confirmation check, to act as a gatekeeper to make sure that at a certain stage of the process, this is not being completely autonomized. This is something that there is a human touch that allows progress to the next step.
And finally, we published a late-breaking medical news article discussing how the recent measles outbreak in West Texas signals a dangerous national trend toward increased vaccine hesitancy, alongside federal actions that stymie efforts to strengthen immunization policy. Experts weigh in on what must be done to counteract misinformation and curb the growing divisiveness around public health communications.
Thanks for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Kirsten Bibbins-Domingo. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.